This session with Dr. Richard Graham. This is a series of 4 webinars. This is the second one of 4, and we've got a round table at the end of it as well, where we're going to bring together some really senior people from different government and other departments to sort of reflect on the lessons we've learned from these 4 sessions. This session is called Stay Connected, and we're going to be discussing the extent to which digital access is now a fundamental of good health and well-being. I mentioned before, just going to mention again that we're recording the session, so please stay on mute if you don't want to be seen or with your video off. And I'm going to invite each of the panel members just to introduce themselves in a moment. Before we do, I'm going to hand over to Richard. So Richard, just to say a little bit about this series and a bit about good thinking for people that don't know about good thinking.
Yeah, thanks, Victoria, and thank you all for joining us today. And it's great to see, excuse me, some of the people who have signed up for this. Yeah, Good Thinking, if you don't know, is London's digital mental wellbeing service that arose about I guess, about 10 years ago in response to the unmet mental health needs, and also then recognizing that digital access was creating opportunities for people to get information, get support, quite discreetly and privately in a way that had always been an obstacle in mental health services. This year, we were talking to people like Shanika Sharma, who will be speaking shortly, about how we could help more Londoners make use of the resources that we've been building up on Good Thinking that are free to access. And that included talking to social prescribing link workers that some of you may know about. The challenge we had almost immediately for Victoria and myself was digital poverty, digital exclusion was a significant factor in their work, such that some people using their services only had a landline number. There wasn't even an email address to communicate with them. And that led us down a really interesting path, really talking to people in primary care, to social prescribing link workers, and those involved in digital inclusion programs, including LOTI, the London Office of Technology and Innovation, who will be speaking at the next webinar. We also were hearing about how giving devices and connecting people without thinking about some of the consequences of that more widely was potentially problematic, and it's really good to see Professor Ellen Helsper from the LSE here today, Professor of Digital Inequalities, and thinking about how digital skills might fit in with helping more people have the choice, and I think we'll keep going back to that, to access digital resources. But part of the thinking about today is, and how we've been thinking with the pandemic, is that there are aspects of health and public health that actually extend beyond one's own individual health. And so that's why we've got this really fantastic panel of speakers today to address whether it isn't just a sort of right for the individual, but almost part of our citizenship to be connected in a way that might be supportive of public health. Our first webinar a couple of weeks ago really led to a conclusion that it was, I think, Victoria, kind of a very active form of discrimination now for people not to have a usable, and I emphasize that every time, usable device and connection, and that if anything, how we help vulnerable groups build digital skills, feel more confident and able to access the resources should they wish to, really emerged across all the speakers. So that was a really interesting development. And we hope to get that uploaded soon and on YouTube so you can see what the speakers were saying. But for now, I think, Victoria, I will pause there because it's really important to be thinking about, whether good health for us all is possible if some are offline, is one of the real challenges that we're bringing to everyone's attention today.
That's a great place to sort of pause and a great provocation for us all to consider. I do seem to have got like the noisiest roadworks just suddenly started up outside my flat out of nowhere, as they do when you're on a webinar. So I'm going to keep on mute as much as I can, and apologies for any background noise. What I'm going to do now is invite each of our panelists to just very briefly introduce themselves and just say a few words about why they're passionate about this topic, why they care about this topic so much. Whilst they're doing that, it would be fantastic if people who are on the call could also introduce themselves in the chat. I can already see that there's some really fascinating people from lots of different backgrounds, and it would just be really nice to get a sense of who's on the call. So if you wouldn't mind just putting your name, saying hello, any particular question or anything that interests you in particular that's made you join this call, it would be great to hear that too, or read that rather. But without any further ado, I'm going to invite Shanika to introduce yourself to start, get us going.
Thank you, Victoria. So I'm Shanika. I'm a GP in Barking Dagenham, a PCN clinical director, and I also work as a clinical lead with the Healthy London Partnership team. I think for me, the reason why this topic is so important, and the title Stay Connected is so important, is that as GPs, all of us go into this profession because we do like that connection with people and we do like that interaction. And the last few months have been really challenging for us in terms of striking that balance, making sure that we are seeing patients in a safe way, and continuing to offer them access to healthcare and to primary care.
Thank you very much, Shanika. And I think there's been some really interesting sort of reports come out just recently, haven't there, about GPs' experiences of delivering services online and for patients as well. And it's a lot more nuanced than perhaps we might have imagined. So so yeah, thank you so much for that introduction. Leah, over to you.
Thanks, Victoria, and hello, everyone. So I'm Leah Jones. I'm a psychologist by background, but I've been working in behavioural science for a number of years now for PHE and now UKHSA. And I'm no expert in digital inclusion and exclusion, but over the years doing behavioural science, it's cropped up quite a few times in the work that I've been doing. So my plan is to speak a little bit about how it's cropped up in the work that I've done and hopefully provide some food for thought for the discussion.
Thank you, Leah. That sounds fascinating. Appreciate you joining us today. And Al, over to you.
Good afternoon, everybody. I'm Al Story, and the day job is I'm the clinical lead of a pan-London street outreach service that's originally cut its teeth mainly in infectious diseases, but has sort of broadened to include a lot of non-communicable disease work, and more recently has had to actually significantly scale to support the needs of inclusion health populations, which are fundamentally people who suffer to disproportionate burden of disease and really struggle to access building-based services, as it were. These would be the core groups would be people experiencing homelessness, particularly people rough sleeping, people struggling with addiction, and usually overlapping mental health problems, vulnerable migrants, a huge agenda around people being trafficked and having recourse to funds, sex workers, etc. My experience with this sort of entire digital agenda has been quite a practical one, but my non-day job, as it were, I'm an academic at UCL, and I've had a great opportunity to actually research some of the interventions that we've piloted over the years, and I'm welcoming the opportunity to share some of our experience of using digital connectivity with some of the most excluded people in the city.
Thank you very much, Alan. I think it's really tempting, isn't it, when sort of plans and strategies and policies are written within health and social care and public services to sort of imagine people with access, highly motivated, trust services, and actually this is going to be a way of solving all the world's problems and creating efficiencies and so on. But what you're describing is people for whom already excluded can be further excluded and marginalised by this sort of exponential sort of surge towards use of technology. So I think this is just going to be a great conversation. Thank you so much. Okay, so thank you for people introducing yourselves. As we go through, we're going to each speaker is going to talk for about 5 or so minutes. It would be great if you could start your own conversation, so questions, comments, any links that you think might be relevant to share in the chat. And then what Richard and I will be doing is we'll be keeping an eye on that chat and then sort of bringing some of those comments into the conversation with our panelists. So please do sort of be active on the chat space. But I think if you're happy, Richard, we should get straight into the provocations, the talks.
Yeah, no, thank you, Victoria. And it sounds like you're about to reach the Earth's core, I think, in terms of drilling. Yeah, if we lose you quite literally down that hole, somebody will get a rope, I think. Right, well, we are going to start with the experiences in primary care, and of course we cannot ignore the pandemic and those experiences that Shanika you've already touched upon. I'm going to now try and share your slides, but if I can't, my esteemed colleague Samira might help us out. So I'm going to just try and see. Right, that's not what I expected, and that's the wrong one. So, Samira, are you able to share?
Of course, I will do that now. Can everyone see my screen?
Looks rather better, really, doesn't it? Rather than business continuity for digital services. Right. Shanika, apologies for that, but not entirely unexpected. Yeah, do let us know what it's been like online, offline, through a pandemic.
Thank you, Richard. And we were talking about psychiatrists and GPs not being the most digitally advanced. Okay,
Nobody spotted it, I'm sure.
Right. So when I was asked to do this, you know, it was very interesting because I was sort of we live this day in and day out as GPs. You know, we always come into work thinking, are we meeting the right people? Are the people that really need to get to us? Are we providing them the opportunity to come through to us? And we always, all GPs ask themselves that question every day. So what I thought would be interesting would be to look at sort of pre-pandemic and then the impacts that the pandemic has had. So pre-pandemic, there was a real push to get general practice more digitally engaged. I remember training and working in practices where everything was face-to-face and you used to have a couple of telephone consultations at the end to discuss some blood test results. But there was this constant push and there was an evaluation of the push as well, which sort of looked at how digital advances were actually having a benefit to patients in terms of giving them more access to improve their sort of mental and well-being, and also access to healthcare as well. And the full details of the evaluation are there. Then COVID hit, and literally overnight we had a transformation where GPs that were working in traditional models had to transform, moving to video consultations, moving to telephone consultations, and also e-consultations as well, to ensure that people could access our services. And this was alongside setting up new services as well, like hot hubs for COVID-19 patients, COVID vaccination clinics, remote monitoring for people looking after care homes, so that residents in care homes could be monitored and looked after in a safe manner. But as we've gone through the pandemic, and as we're still in the height of the pandemic, it's clear that digital advances have their benefits in terms of a wider outreach to a greater sort of cohort of the or greater sort of population coverage in terms of reaching out to people. But there is also a clear and strong relationship between groups that are and feel digitally excluded. And there are a number of reasons why people may feel digitally excluded. And what I'm presenting to you here is from a report done by Health Watch earlier on this year called Locked Out, which is really useful. And they looked at some of the main reasons why people may feel digitally excluded. And you've got the list there, and that's in terms of how frequently that cropped up. So limited interest in technology was top of the list. And language barriers as well was a significant problem as well. And also comes this question about affordability and the impact that has on digital exclusion. But what we've done in primary care is we've really looked at how we can empower people to use the transformation, and also the people that might not have access or might struggle to have access, how we can help support them. So some of the things that have been happening through social prescribing and other teams is looking at health literacy and trying to enable people to manage their health and care, giving them a better choice and convenience, because this was one of the things pre-pandemic that we used to get in terms of feedback from patients saying, you know, your working hours don't work around my working hours and I can't get in to be seen. So choice has come up time and time again as something that patients really do want. Improving relationships between how we communicate with patients. And now we've got lots of channels of communication, whereas before it was pretty much phoning a GP surgery trying to get through. Now there's lots of ways you can communicate with your GP surgery, and GPs are also looking at how they can improve their telephone access as well for those people that can't get onto digital means by telephony. And then there's also sort of looking at the cost and the burden on frontline services and how we support teams, because primary care teams have changed now as well. So before, you know, it was predominantly a GP within a GP practice, but now you have teams with physiotherapists, social prescribing link workers, care navigators, a whole array of multi-professional teams and a real multi-professional model that we're working towards. So how do we get the patient to have access to the most appropriate individual who can meet their healthcare needs is what we're really aiming towards. The key principles of digital healthcare that have been highlighted in this report is that what we should try and aspire to do is to maintain traditional models of care, because we know they work, we know primary care works, and we know that continuity of primary care works as well. But how do we keep that alongside remote methods, supporting patients to choose the most appropriate type of treatment to meet their needs? There is investment that's going to be needed in terms of supporting as many people as we can in that journey as well. And also looking at patients' rights in terms of remote care, which was touched upon earlier by Richard. I think that is a very important principle as well. We've also been doing a lot of proactive care, which has been really important, and really reaching out to people who we feel have not contacted us and need to be spoken to. So that work has happened as well in the background. The key learning from the COVID-19 pandemic is that people have found it more difficult to access face-to-face appointments. And this has been for a wide variety of reasons. Practices have had challenges in terms of staff isolating, staff being unwell. Unfortunately, we've lost a lot of primary care colleagues throughout the pandemic as well. So that has had an impact. We know that remote care can remove obstacles for some, but can create barriers for others. And we need to think about how we can help support those people that are finding barriers more of an issue. Choice is what we touched on earlier. When we've done staff surveys, the feedback we've got from our primary care teams is that they'd like to continue with a hybrid model because they feel that offers choice to patients in terms of access and also support in terms of access. For example, care navigation and also active signposting can really help. As an NHS organisation, there's lots of ways in which we can sort of look at championing this and working on this. For example, the use of digital health champions. A lot of social prescribing teams have been creating digital health hubs in the community. And this works for a lot of things, not just for healthcare, but it helps to empower patients to use this digital technologies for other aspects in their life that they may need to use that with. And it also sort of brings a community together as well. So, you know, we've got libraries set up, we've got online centres set up where people can come. It also helps with isolation as well. They can meet others and they can learn from each other. So in conclusion, there's been a lot of transformation in primary care, but I know that myself and my colleagues in general practice have really tried hard to go through the transformation, which has been a very rapid transformation, whilst maintaining access to the best of our ability and making sure that we do offer services to those who need to contact us. Thank you.
Thank you very much, Shanika. Really interesting stuff. Just a quick question I've got before we move on, and Richard might want to come in as well. It just strikes me that what you're trying to achieve in terms of health champions and digital health hubs, it strikes me that needs to span way beyond the NHS. And have you been working with local authority and sort of third sector colleagues to stand those sorts of things up?
Yes, we have. So in most areas, you have borough-wide partnerships developing. And these borough-wide partnerships bring together all those key stakeholders that you mentioned, for example, the local authority, community services, primary care, And it's really looking at this together, because I think it does need that collaborative approach. And this is also where primary care networks come in as well, because it's looking at the holistic model that we can offer.
Shanika. Richard, I'm going to hand over to you for a comment and then to introduce our next speaker as well. I'll go on mute.
Yeah, thanks, Victoria. Yeah, I just wanted to say in relation to the digital health champions, I think one thing we're starting to learn, Shanika, is how we help them kind of teach digital skills in themselves. That I think there's much learning, and I don't know, Ellen, whether later in the session you may be able to come in on that, but this is emerging more and more with different vulnerable groups, different faith groups and so on. There needs to be nuanced approaches to how we help them acquire digital skills that might then give them that choice to either have a remote consultation or contact with you or face to face. So I think that is going to emerge for us. I think it's quite a key issue, but this is a subject that needs much more time than we can ever devote. So I am going to move on to Leah Jones. Leah, I guess since we set this up, your title seems to have changed because of, I guess, Matt Hancock's inspirational approach to public health as well as wider health services. So if you want to remind people, but we first had contact at the beginning of this year around the issue of vaccine hesitancy and different groups where, coming from my side, from a media literacy, e-safety perspective, we were worried about the impact of disinformation. But as people like yourself were talking to communities, things were far more complex and nuanced. And we've just had some really interesting conversations. But I guess in terms of rolling out vaccines and getting that uptake of COVID passes and all sorts of things, digital has played a key part in our pandemic response. So I know you'll have lots of really good things to share. So let's let you talk.
Thanks, Richard. Yeah, I will just share my screen because I've got a few slides that I'd like to share with you guys. Bear with me. There we go. Can you see my screen?
Yep.
Excellent. I've still not figured out how I can look at the chat and present at the same time. So, you know, as this is a discussional workshop type thing, you know, feel free to jump in if anyone has any questions or thoughts as we go along. But yeah, so I'm Dr. Leah Jones. My background is psychology, like I said, and I work in behavioural science and have done for a number of years. Pre-COVID, I worked primarily around primary care and common infections. And as COVID kind of took over, my role moved more into COVID type behaviours. So as Richard said, vaccine behaviours, testing behaviours, those sorts of things. And I'll draw on some of my work from, you know, pre-COVID and during COVID. And actually a lot of it relates to what Shanika was just saying. So hopefully this will be kind of a continuation of the discussion. But I think importantly, like I said, I am not an expert in digital and exclusion and inclusion, but it has cropped up a lot in my work. And I think there's a lot to be done here. And I think there is a huge role for behavioural science in this arena. So the first thing I wanted to talk about, there we go, is some of the work I did pre-COVID. So as a behavioural scientist, a lot of the work I used to do was around intervention development, intervention evaluation, around common infections, as I said. So some of the things I used to do was develop patient information leaflets, you know, really simple interventions to help clinicians to communicate information that they need to patients. And one of the interesting findings that came up a lot in the work that I did was how GPs and primary care clinicians are really moving into an electronic format. So you can see here there's a headline from the RCGP. Text messaging can be a really valuable tool in general practice. And also one of the findings from my study here under accessibility, general practice staff would like a leaflet to be made electronically and in hard copy to suit their preferences for dissemination, as some prefer texting or emailing leaflets, whereas others prefer providing hard copies. And I've got a little quote here from a GP who said, so bits of paper get lost in piles, But if you've got it electronically, so you can print it off or text it to them, it's easier. And that was a fairly common theme of clinicians liking their ability to just text a patient some self-care information or some prevention information via a leaflet. And a lot of people said that they don't have room in their consultation rooms to have hundreds and hundreds of different leaflets for all the various types of illnesses or infections that they might see. So having things electronically is really helpful. It's a great tool that they can very easily send to patients, and it's something that they can refer back to and look at, and kind of reinforces the understanding of the information they're giving. So a real positive. And a lot of the patients that I spoke to agreed with that, and they liked having that option. I've got a quote here from 2 older adults that passed their leaflet on to friends and family. So they had it in hard copy. And the quote is, "What I've done is I've photocopied yours just to give it to my daughters because this sort of information is invaluable." So they liked having a hard copy that they could share with other people that they thought might be interested. So the thing about leaflets, and I realise this is a very small niche area of health, but you can kind of see how this can be extrapolated to wider areas of health, not just primary care, not just leaflets, but it's a kind of microcosm of what is happening across healthcare. And this movement to communicating digitally is great and it's fantastic, and we can see it here, but also it can be quite negative in the sense that if a GP or a clinician doesn't have hard copies of leaflets, for example, and they really have moved over to electronically, they're communicating information verbally. And with a leaflet, you can reinforce that information. And again, it's something they can refer back to. Whereas those that maybe don't have that option to receive a leaflet electronically don't have that information, or they maybe don't get that level of understanding, because the leaflet is essentially a communication tool and a really valuable communication tool. So it's a slight extrapolation, but this is really important because in terms of being able to self-care for a common infection or prevent future infections, or knowing what the red flags are in terms of symptoms to look out for and knowing when to go back to your clinician, all of that information is really important in terms of health outcomes. If someone with a leaflet can refer back to it in a month's time when an infection re-emerges, or if they get similar symptoms, they can potentially self-care for it and not need to go back to see a clinician, or they might not even need a prescription or an antibiotic. So there's implications in terms of health outcomes here. So I know we're only talking about patient information leaflets, but actually it has wider implications. So this is the sort of thing I was doing pre-COVID. And then since moving on to COVID work, I did a piece of work last year where I was speaking to people from different minority ethnic groups around their experiences of the pandemic. We discussed anything and everything to do with the pandemic. And this piece of work isn't published just yet, but what I'm going to talk to you about is just the notes and observations from one particular focus group. So it's not, doesn't necessarily reflect the whole findings from the study. But this was a really interesting and important focus group that I conducted, and a particularly difficult one to conduct, actually. It was with a Black African group from very deprived backgrounds. So this particular group, they had no access to electronic devices at all, and one even had difficulty accessing a phone in order to participate in the focus group. So as you can imagine, I was really fortunate to be able to get their views incorporated in the study. So that was really, really valuable. One of the key things that came out of that particular focus group was that during lockdown, they weren't able to attend in-person mental health support groups, obviously, because those kinds of things stopped happening. The difficulty was they had no electronic devices to maintain any form of remote contact. So that support immediately stopped for them. They described the pandemic as being the worst thing that they'd ever experienced before in terms of the impact on their mental health and the isolation from others. So they'd been told to isolate, but they were concerned that no one had actually checked in with them. They said things like you feel unwanted and unworthy. and you are lost. They had a real concern around the lack of funding to support those organisations that were providing that support and what would happen to them moving forwards. And they realised in themselves that they needed an electronic device in order to access information about the pandemic and what was happening and stay up to date, but also to continue receiving that support. So they really recognised that need in themselves. But I guess what I'm saying here is that this is a wider issue, right? And the pandemic has really highlighted that, and it highlighted it for the individuals, and it's highlighted it for us. There's definitely lessons learned, and it was nice to see Shanika kind of highlighted those in the ways of how we can adapt services to really support these people, especially if something like this happens again, where all of a sudden we're in a lockdown situation and we really need digital devices to maintain contact with people. And it's not just, physical health outcomes, it's mental health outcomes as well. So that was particularly interesting focus group to have. And then just very briefly, because I'm aware I'm going on a bit longer than I probably should have done. One of the pieces of work that we do within our unit is we put together briefing notes. So we put together the literature around various different behaviours. And one of the briefing notes we have is around self-isolation. And adherence to self-isolation. Now, of course, maybe not the issue isn't, it's not a big of an issue now, but it certainly was last year around adherence to self-isolation, but also the impact that digital exclusion has on people's ability to self-isolate. And the literature was showing that some of the issues here, of course, as we know, relate to financial barriers to Wi-Fi, access to the devices, access to data. So you might have a device, but you might not have access to data. The cultural and religious practices, also low literacy, language and digital skills. So there's a lot of issues here that relate to just simply being able to self-isolate. It becomes even more problematic when you add that in with the issue of potential fines and issues relating to not being able to adhere. And obviously, things like that just widen the health inequalities gap. So that was a very quick whistle-stop tour of the kind of work that I do, but hopefully this has provided some food for thought and will hopefully kick off some interesting discussions. So yeah, stop sharing the screen.
Thank you very much, Leah, and I'm hoping that everyone will be happy to share the slides because I can see there's some good references on there as well. And just to make it really clear, in terms of that last slide or the penultimate slide you had around digital exclusion, meaning that people couldn't self-isolate, was that around people not being able to do things like online shopping or the things that would enable them to stay at home?
Yeah, exactly. So if you remember, of all even for us, right, that we're using digital devices, it was difficult to get an online shopping slot, wasn't it? It was really, really difficult. But one of the main barriers for people when it comes to self-isolating is having to do a last-minute shop. You've had this notification that you need to self-isolate. Well, I've got no food in the house and I need to stay in here for 2 weeks. So all of a sudden, this option of being able to do online shopping is impossible. You've got to go out and get food, especially if you've got no one else around you that can help you. You've got to go out. So it made it very, very difficult for a lot of people.
Thank you, Leah. And I'm going to hand over to Richard for a comment and then to introduce the next speaker.
Yeah, no, I just think, as with some of our previous speakers, Leah, the poignancy and almost distress of hearing how not being able to get that connection during lockdowns, during COVID, the worst thing. We must never forget that, even if we need to remember the leaflet is still important for many, many reasons. But I think this will kind of moves on perfectly, Al, to your work, then working with many types of vulnerable community in terms of their being, I guess, on the edge of using traditional services well before COVID and really what that means for them. But as I also said at the beginning, the health for all of us when we're talking infection control. So I'll say no more, Al. Be good to hear.
Thank you very much. As a reflection of my digital literacy, I have no slides. So I shall be I shall be relying on the voice So I'm going to tell you a bit of a narrative. So I'm going to cover a service that we set up, well, way back in 2007. This story starts, and it's a service that basically was designed to support some of the most vulnerable people in our society who had tuberculosis, and given the huge challenges of completing a course of medication and the imperative to complete that medication, we've historically, used something that is called directly observed treatment, directly observed therapy, to support people to take that treatment. I'm going to share with you a digital alternative to that, which we actually did an RCT on. And then I'm going to talk very briefly about during the pandemic, during the Everyone In government-led program to basically get people who were sleeping off the streets during the lockdown. And then just a few next steps and reflections from me. So I think it's already been covered that the pandemic has massively accelerated the entire digital health agenda. But with that acceleration comes inevitably the acceleration of inequity, and the widening gap in terms of access and opportunity as far as the digital health agenda is really a big issue now, I feel. So I'll start way back with a young male who was diagnosed with what we call XDR-TB. So he's got to take treatment for 2 years. The treatment's nasty and highly toxic. And at that time, in 2007, he had about a 60% prognosis, so 60% chance of survival. He needs to take medication in the morning and in the evening, and he's homeless. And the alternative that was offered for him was to come to a hospital in London twice a day and be observed taking his treatment on the ward, which would have cost him a small fortune and taken up basically all of his day. So we raided the stationery budget and provided him with a very, very cheap, at the time, sort of notepad device. Things were very clunky in 2007. It's hard to remember, how slow things used to be. But basically, we set him up on this device, gave him a dongle with some data, and trained him how to video himself taking his treatment. I gave him the option of doing it synchronously or asynchronously. He preferred asynchronously, and we check in with him pretty much every day just with a phone call, and he would send videos of him taking his treatment. And despite the fact that he was homeless, he was sofa surfing, he was committed to the treatment, and he never missed a dose. And this sort of opened the door in terms of our thinking about, well, what can we do with this technology to support people who need to take those very long courses of treatment? So we eventually managed to get funding for the world's first randomized controlled trial. It was an interesting conversation with the ethics committee. So we're basically saying, so we want to randomize people who've got long histories of homelessness, drug use, etc., imprisonment, want to randomize them to give them a smartphone or usual care. And everyone just thought, well, they're just going to lose it, as it were. So we embarked upon this trial with some skepticism, as it were, in terms of the outside world. And the trial was actually had some a priori stopping points. And we had not even recruited to power. So we were literally about 18 months into it when an independent committee looked at the data and told us to stop the trial because the difference between the two groups was so marked. It wasn't considered ethical to continue to not give people the option of a smartphone. So we try to unpack this sort of, it's a trial, it's been, through the sort of causal pathway, it's logical reductionism gone mad, and it's a complex intervention. So in essence, we were trying to understand what made it work. And so we also undertook quite a lot of qualitative research alongside this. And, the things that came through in terms of why it worked were, first and foremost, I think the asymmetry of power, the idea of if you're visiting somebody in the community, it's at a time that's, you fix, etc., the provider fixes. If you're asking them to come to clinic, it's that asymmetry of power in terms of the patient-provider relationship. And so, this idea of having a much greater degree of choice and control, I think was really important. And some of the feedback that we got through qualitative work was just amazing. I mean, one thing that really strikes me is a guy who basically had previously failed treatment on more than one occasion, and he just loved the idea that he had the nurse in his pocket. But anyway, he felt very empowered by it. I suppose the next thing was that the idea of regularly medicating is about habit forming. We work with people who have vastly different life expectancies to the general population. And when you actually unpack all the data, I mean, the big ticket items in terms of suicide, self-harm, overdose, big infection issues, etc. I mean, they are hugely overrepresented in terms of an adjusted odds ratio. But the premature death is predominantly driven by the common things. It's cardiovascular disease, it's respiratory disease, etc. And it's people's inability to engage with, or rather our inability to provide them with a platform to engage with long-term care. So the prompt issue was very important. It was sort of habit forming, and it was incredibly easy. It was done, as I say, on their own terms, in a way that suited them, at a time that was suitable to them, in a place that was suitable to them. So it basically massively reduced side effects, because a lot of people taking MDR treatment experience awful side effects. And we found that nearly all the patients decide to medicate late at night and have much less adverse events during their treatment. It got rid of a lot of the stigma of visiting people and asking people to come to you. And it was actually an enabler also, in the sense that we gave people a device. It wasn't the latest iPhone. It was a perfectly functional smartphone. It costs us £50 now. But nevertheless, this was a significant door to access other opportunities in terms of digital connectivity. And so lastly, it was an incentive. And providing incentives is not uncommon in terms of supporting people who are destitute to engage with care. But I think we need to realise now that data is in itself an incentive, and data was a powerful incentive. And when we actually unpacked the reasons why we had such a low rate of loss of the devices, it was actually because of the free data. People are invariably using any old device just to sort of use free Wi-Fi, etc., and connect to different things through apps, and you can pretty much function without a data deal. But if you have a data deal, it's a game changer, and giving people free data was a huge incentive to enable them to not only engage with our care, but also to sort out other things in their life, like apply for benefits, etc. So this sort of trial sort of led us to believe that there's a huge opportunity here to expand the use of this. We've changed the name of it from VOT, which was video observed treatment, to video supported care. And in fact, we've done a lot of pilot work in other conditions, principally HIV, Hep C. We're working to build a better evidence base. Fundamentally, digital health is still in its infancy within the NHS. So we need to build a better evidence base, and we want trials that have strong clinical endpoints. So that would particularly be useful in terms of HIV, Hep C, etc., mental health interventions, and opiate substitution treatment. So there are a number of a number of sort of balls in the air on this one. But if there's anyone out there who'd be interested in a conversation about this, we'd be delighted to hear from you. Now, secondly, during the pandemic, we undertook what is actually the largest and most comprehensive health needs assessment of people who were rough sleeping that's ever been done in this country. And we did it entirely through smartphones on a digital platform for a group of people who had been given the unprecedented offer of free accommodation to isolate during the lockdown. Isolation comes with many risks, not least the sort of mental health issues of being cut off from the world, etc. But so we launched a very comprehensive health needs assessment that was actually designed to identify people's ongoing needs and plug them into care, principally to plug them into care. And one of the most striking things that came out of that, from a sample of more than 1,500 people, was that 20% were not registered with primary care at all, and a further 25% were registered, but it was a practice that was a million miles away from where they were geographically or in terms of their any ability to access that service. So pretty much half, to all intent and purpose, had no real connection with primary care, which we thought was horrific. The the first intervention obviously was to engage people who had, immediate urgent care needs. But as we sort of worked through this quite sizable cohort, we've ended up with nearly all of them now engaged with primary care. Unfortunately, they're very peripatetic, so that still remains a big challenge in terms of sustaining any sort of engagement. I'm conscious of time, so I'm going to wrap just with a few next steps. So, when we think about connectivity, we think about sort of the digital revolution. Our work in terms of our inclusion health agenda at UCL, at the Collaborative Centre for Inclusion Health, is very much trying to take a rights-based approach. And I think we have to kind of think about digital equity within the context of a rights-based approach to care. I was very fortunate to visit the States a few years ago with a colleague and visit many of their sort of hostels, and was just blown away by the fact that they had these huge charger points for people to securely lock their device into a little box and charge it, and they would go back out on the street, but they had what was called Obama phones, and pretty much it was ubiquitous to have a device. It was almost impossible to engage with services on the streets of Los Angeles without a device, and we've come to think that similarly in terms of accessing not only the health service but a myriad of other opportunities, not least having a COVID pass, for instance, to get into a building, you need a device. So I suppose for us, the next steps around building this evidence base are really two things. One, as I say, we want to expand the idea of this video platform to engage with care, and particularly around those long-term conditions, the conditions that are really driving premature mortality. I think the gap in the market for us in terms of our experience from doing that large comprehensive health needs assessment is the fact that there is a big digital health primary care agenda, and in fact I go further, there's a big MDT agenda for this client group. Their care is very fragmented, and their health experience is really defined by very early onset complex comorbidity, including mental health and addiction, and it requires a full-on MDT approach. It's not something that you could manage in isolation. It also requires the input of advocates, in many instances translators, and the digital platform provides a real opportunity for professionals to come together and provide that sort of MDT approach as part of sort of case management, as it were, rather than in response to crisis. I suppose the digital agenda in terms of the IACs, the immigration assessment centres, we're currently supporting over 10,000 people who are in emergency accommodation across London, many of whom have had pretty horrific journeys. And owning a device throughout those journeys, to be trafficked across the Middle East, to be in the camps in North Africa, that smartphone has been a lifeline. It has been the means of survival for so many people, and they are extremely competent users of this technology and very, very, very keen to engage with a digital health platform. And so we want to try and expand that. But I suppose the last thing and the most interesting thing that we're really keen to try and work on is the idea of moving from asynchronous, as it were, recording, sharing videos, to the idea which sort of blows me away in terms of why it's not the norm in our health service already, to actually use the video, the record of the consultation, as it were, as the medical record. We've got a lot of interest in this from primary care colleagues, mental health, people in addictions, and patients themselves are very keen to actually not only have access to their record so they can review it, because people remember so little about what was actually said during the consultation, but to also be able to have, again, back to that MDT idea, to have a platform where they can invite a trusted advocate in to actually support them to get the most out of communicating with professionals. I realise I'm over time, but the last thing about that sort of idea of recording the consultation, I think it will quite markedly change both patient and provider behaviour and probably drive quality within the service. And we're very keen to pick up conversations with that. Thank you very much.
Wow, Al, you've given us so much food for thought. It's almost hard to know where to start. I mean, I'm sort of reflecting on two things. One, that sort of rights-based approach, which I think is really fundamental and really interesting. And secondly, your point about multidisciplinary teams and how you could help teams coordinate more effectively. And I'm just going to pick up on a comment from Nikki. Hello, Nikki, in the chat, who asked about this sort of digital navigator type role, digital champion role that you first introduced, Shanika, in your talk. And I just wonder whether we might start seeing those roles as part of multidisciplinary teams for those people who are less confident. And Nikki was keen to hear about any practical examples of how or what's making those sorts of roles work well. So I'm going to open that up to the panel. But Al, maybe first of all, is that in the work that you're doing, are you incorporating sort of training, support type roles when it comes to use of technology for those who are less confident?
That's a very good question. I mean, for many, it is second nature now. I mean, for most, they're more than capable of showing me a few tricks. I mean, I'm a bit of a Luddite, but we've worked very closely with an organisation called Expert Focus, who are a organisation run by a group of people with lived experience of homelessness, and their mission is to basically use digital platforms to promote a whole sort of PPI agenda to enable people to actually, you know, be fully involved in service design and fully involved in actually trying to sort of shape their own health agenda. And Expert Focus provide a very structured program of training of how to use devices, including sort of the digital literacy agenda, but also, and equally importantly, the sort of safety and security agenda. So yes, we've got a quite a vibrant program of engagement, and particularly to try and engage people who would otherwise struggle to use those technologies, because again, you know, you introduce an intervention and along comes intervention inequality. So I think we need to be very mindful of rights to access.
And I think a good point about working with advocacy and survivor groups and so on to bring that sort of particular perspective and support. Shanika, anything you could share in terms of what's worked well or what might be sort of useful for other areas, thinking of this sort of digital champion type role?
So what we're really trying to work on in the patch where I work, which is Barking and Dagenham, is creating community hubs. We've sort of mapped out for our borough what those community hubs would look like. And this is all stemming from the borough-wide partnership work, because if we have those community hubs, then we can sort of put the digital support offer within these community hubs for people to access. And I know our social prescribing team have been working really hard on this. And if we can create these hubs and we can embed all these models of care within these community hubs, so they're closer to home for everybody.
Thank you for that. Yeah, I mean, the other place to look actually is we had Emma from the Good Things Foundation on our webinar last time, and they have tons of good resources around creating those sort of community hubs on high streets and in lots of different places. So, you know, really worth checking out. Richard, I'm aware we're woefully running out of time. I wonder whether we've got time for a few sort of final comments from you, and maybe just to talk about the next session.
Yeah, just a couple of observations. I think that it is really interesting, the digital skills element that I think we will find runs through. But I was struck, Al, and it does link with Leah's presentation as well a bit. In terms of the work you're doing, presumably there is a public health dimension that when you're supporting those individuals, there are wider sort of health and economic sort of aspects that are beneficial to us all, because that certainly seemed to be the case around isolation layer, testing, vaccine, perhaps now passes. So that's one question, but also really interested that it's supported, and going back right to the beginning and staying connected, Shanika, use of primary care services improved through the work you were doing, which again must have all sorts of beneficial sort of impacts more widely. So just a few thoughts there about everything from health economics through to that fundamental staying connected in a way that supports people and helps them feel someone cares. But I think we're moving in terms of the rights direction, Victoria, that you can't do that, and for £50 and free data terms of costs to other services in health, that's not such an expensive intervention.
Well,
sorry. Yep.
Sorry, go on. I'm having a few problems with my laptop. Apologies.
I didn't really cover the sort of cost-effective dimension to it, but it is extremely cost-effective. You know, as you said, the device is £50, and as a provider running a network of phones, you know, we basically pretended to be a company, so we were able to share data across a huge amount of different devices, and indeed still do that for a national service. So it is very, very cost-effective. But we've only really looked at it as usual. You know, the crime we usually commit, we look through the lens of the NHS, through a very health sort of related lens. If we were to do some more erudite cost effectiveness analyses that actually took a sort of more societal perspective, I think we'd see huge increase in the value, because again, you know, back to the ideas of, you know, just from a housing perspective, from an engaging with a myriad of other different services, it's pretty much all online now. And if you haven't got that device that enables you to make an appointment, change an appointment, find out a piece of information, use a map, etc., where is the service, send a text, I mean, you really are in the dark in the 21st century.
Yeah.
I think that's a good point on which to sort of conclude, and I would love to see that sort of evidence to help advocate for that approach. Back in 2014, we bought a load of devices for a community mental health rehab service, and we were terrified we were going to end up in the Daily Mail, you know, as a headline for you know, using public funds inappropriately. But actually, it had a massive impact on the people that lived in that unit, just being able to do things as you say, I'll just get about and plan their journeys and so on. So I think just that very basic level necessity for technology is not to be underestimated. Richard, we've got our next session in a couple of weeks, haven't we?
Yes, and almost by magic, the first speaker at that event, Professor Ellen Helst, has just put something really interesting in the chat. So Ellen, if you can share that link later, because I think then, as we've heard from Nikki Runicles, this interest in how one might develop these skills as digital champions, digital health champions, as part of this sort of matrix of support to reduce inequalities, which we know you're committed to. We'll also have speakers from those involved in digital inclusion programs and some interesting perspectives from Cliff Manning, who worked with the Carnegie Trust on the Not Without Me project. I think Al might be trying to escape, but he's still listening. I can see it's a hot desking world still. But yeah, I absolutely terrific session, and it feels like we might be involved in some sort of movement, Victoria, rather than just sort of developing good thinking aspects.
That was our secret agenda. So good to be having these conversations and this debate and discussion. Thank you so much to our speakers, and thank you to everybody who's joined us today. We've got another session this time in 2 weeks, and then another one before we conclude. So please do join and sign up to our next ones, and we're delighted to have Elspeth on the next one, so we're very looking forward to seeing her there. But have a lovely afternoon, everybody, and yes, thank you for your time. Cheers. Bye-bye.
Thanks, everyone.
Thanks, everyone. Bye.
Bye.